Okay, let's consolidate our knowledge a little bit. And so this is my approach to acute kidney injury, or this is at least how I think about it. When you're seeing a patient, let's at least consider, is it true AKI or is it actually newly recognized chronic kidney disease? So, if it happens in the hospital and you clearly have a change in the urine output, a decrease or an increase in the serum creatinine, well, that makes it pretty clear it's AKI. But sometimes a patient will show up to the emergency department. Their creatinine is now, 5, 6, or 7, 8 milligrams per deciliter, and you look in the records, and the last one you have is 1.5 a couple years ago. Well, because it's hard to know if it's AKI or just advanced CKD that's now newly recognized and symptomatic. And this is a shrunken, atrophied kidney. One thing you could do, you could do a ultrasound. If you see increased echogenicity or decreased cortical thickness or decreased kidney size, that could be a sign that you're dealing with CKD instead of AKI. It can change how you sort of manage the patient or think about it, but certainly if it's AKI, you want to be interested in the diagnosis so you can see if you can reverse it or not. Next, for hospital-acquired AKI, and so this is just a term I've made up, and the way I think about this is a patient comes in, creatinine's 1, it's completely normal, and then at some point during the hospitalization they develop AKI, and so sort of my go-to paradigm is I think, what did we do to the patient? And by we, I mean just the healthcare system in general. I start looking in the chart for, what surgeries or procedures have happened, when and where was IV contrast administered, most importantly, what medications were given, when and where, and to what quantity. Did the patient develop sepsis? Have they developed any hypotensive insults? So those are the key things I'm looking for, and I think in the vast majority of the time, you can find a reason, and one of these causes is for, what was the event that maybe led to hypotension or poor perfusion of the kidney, and then maybe in the certain context of certain medications or comorbidities, it led to AKI. Next, for a community-acquired AKI, for lack of a better term, this is something that develops while the patient's out in the community or at home. And for these kind of patients, it could be anything. I mean, it could be sepsis or hypotension or medications or other things, but this is also where patients do develop de novo intrinsic renal diseases that are sort of idiopathic or affect random people, like the glomerulonephritis or anything that can cause a nephrotic syndrome. So for patients like this, I want you to keep a very broad differential diagnosis and really put on your thinking hat and use all the data that you have available to make the best decision possible. Okay, so here's one way to organize everything. So it starts with the clinical assessment, and obviously seeing the patient, asking about volume status, especially volume loss at home. So we care about poor oral intake, nausea, vomiting. We ask about excessive diarrhea, use of diuretics, anything that could result in excessive fluid losses from the body. We also ask about symptoms of hypotension or symptoms of volume depletion. So ask multiple ways, sort of the same question. Ask about dizziness, orthostasis, feeling lightheaded, because I think those things are instructive. If the patient feels lightheaded, well, the kidney's feeling lightheaded too, and that could be good evidence of volume depletion. Also, we introduced this concept in the first video about global perfusion. Kidney blood flow is the mean arterial pressure minus the renal venous pressure divided by the resistance, and so I think about each of these components. So the mean arterial pressure, this could also just be the effective pressure at the level of the kidney. For instance, if there's a inflow vascular lesion, atherosclerosis, or fibromuscular dysplasia, that would obviously affect blood flow to the entire kidney. Renal venous pressure, well, we don't routinely measure this directly, but we can estimate it by assessing the entire volume status of the patient. If they're showing signs of fluid overload, like elevated JVP, pulmonary rales, and pitting edema in the lower extremities, that could be a sign that the renal venous pressure is probably elevated as well. It's difficult to measure the resistance, but remember, in a couple settings, we know when the renal resistance is increased. If the patient has known arterial sclerosis, so stiffened vessels, probably can't autoregulate as well as they could otherwise. Patients with heart failure or cirrhosis probably have increased resistance due to elevated sympathetic nerve activity, and also patients who are on things like calcineurin inhibitors and whatnot. So when we're thinking about acute kidney injury, we care a lot about vital signs, orthostatics, if needed. If there's any question, we really care about the physical exam to assess the fluid status of the patient, either they're euvolemic, hypovolemic, or hypervolemic. Sometimes we can use something like a urine sodium to help us gauge whether perfusion to the kidney is effective or not. So, urine sodium is very low, and so you would only order this in the setting of acute kidney injury. So if it's very low, that suggests there's intact tubular function as the kidney is holding on to sodium aggressively. But if the creatinine's up and the kidney's holding on to sodium aggressively, maybe that's a sign the patient is hypovolemic despite your exam. But I think a lot of people can probably figure out that a patient needs IV fluid based on their fluid status or vitals and orthostatics. But sometimes we use this or even the fractional excretion of sodium to help. But these are the key components that you should at least consider on every patient. And next, when evaluating someone for acute kidney injury, it's worth considering some form of imaging of the kidney. And so we do tend to use like a renal ultrasound with Doppler especially, because it can give you a lot of information. Number one, if there's obstruction, you could identify that in the kidney. Obviously, this would be sort of obstruction outside of the tubule, so anywhere in the ureter, in the bladder, or in the urethra or prostate level, you would potentially be able to pick up obstruction that way. Also, when you're using Doppler imaging, you could identify inflow, so you could look at the renal artery, but also outflow. You could look at the renal vein and make sure both of those are patent and not being obstructed or not full of thrombus or something else. So imaging can be very helpful. Also, in our kidney transplant patients, remember all their kidney function is coming from this one kidney. So obstruction and compressive effects are more clinically apparent. So it's not uncommon for a fluid collection or a hematoma to be so large and so high pressure. It actually compresses the kidney or compresses the vasculature, or we've even had kidneys that sort of torque or twist on the vascular inflow or outflow, or resulting in kidney failure. So all these things could be identified pretty rapidly with a kidney ultrasound. So kidney transplant patients, we tend to order a renal ultrasound quite often. For patients without a kidney transplant, they have two native kidneys. We probably do order too many kidney ultrasounds. And, in my mind, I think, maybe like an older man, deserves a renal ultrasound for acute kidney injury just because BPH and bladder outlet obstruction due to a large prostate, could get missed otherwise. And so that's a more common cause of obstruction. Maybe anyone with intra-abdominal cancer, a female with cancer, you'd want to do ultrasound to make sure there's no obstruction of the ureters by some malignancy. But, if there's a really straightforward or excellent explanation for the acute kidney injury, you probably don't always have to get the ultrasound, but we typically do just to rule this out because you don't want to miss this because it's easily reversible in most cases. And last but not least is we need to look at the urinalysis. So every patient with acute kidney injury, I believe, deserves a urinalysis and possibly urine microscopy. So the urinalysis is something done in the lab, but urine microscopy should be done by the provider. And so this just is a simple test. You just need a microscope and a centrifuge. You obtain, fresh specimen of urine. Early morning urine is great, and then spin it down, find the pellet, and then spread it on a slide, and then put it on a cover plate and view it under a microscope. So this can give you a lot of information. First of all, you may identify crystals in the urine. So if you see crystals, there's a variety of shapes and sizes that can occur, but whenever crystals are seen on urine microscopy, I say, go to the computer or a book, do research on all the varieties of crystals that can appear in the urine, then compare what you see under the microscope to your research and try and make some sort of a guess on what you think is present, and then also look at the medication list to see if you can identify any medications or other substances that could explain what you're seeing, because you may be making the diagnosis of tubular obstruction due to crystal deposition. Next, it's fairly common to see these muddy brown or granular casts that are indicative of ATN or acute tubular necrosis, so especially in hospitalized patients. So if you see this under the microscope, there's a lot of debris, just sort of small granular debris. And then the thing you're looking for are these tube-shaped cast-like structures where the stuff in the cast are these fine little, dark brown granules that are definitely smaller than cells, smaller than red blood cells. So that is indicative of ATN. So very common, and you'll probably see it quite often. Also, on urinalysis, perhaps you could see pyuria. So you see white blood cells in the urine. If you see, maybe a little bit of protein or no protein, or especially if you see white blood cell casts, those would all be, urinalysis that's consistent with interstitial nephritis. So there's a process where there's intense inflammation in the interstitium of the kidney and results in typically pyuria. So remember, pyelonephritis can do this as well. And so if you see pyuria and the patient hasn't had a urine culture yet, it's worth getting your urine culture to rule out severe urinary tract infection. Remember, also just, cystitis can result in pyuria without interstitial nephritis. So you're only seeing a patient with acute kidney injury. Make sure you ruled out cystitis and pyelonephritis. And then, if you see a white blood cell cast, that's pretty specific for interstitial nephritis. Next, if you see urinalysis with microscopic hematuria, so lots of red blood cells, maybe a red blood cell cast and extensive proteinuria or albuminuria, that strongly suggests a GN. So this is what we call a, quote, active urinary sediment. And so the presence of albuminuria is very specific for glomerular involvement. And so the things we're looking for when we look at the urine and under urine microscopy, one question is there a problem at the level of the glomerulus? And so, finding red blood cells, especially red blood cells that maybe look a little deformed or chewed up, and especially finding proteinuria, albuminuria, that's a strong sign that the glomerulus is involved. And so, obviously, every patient with AKI, UA and a urine microscopy can help answer that question. And finally, the last pattern you may see is a urine that's completely bland, which means there's no cellular material, no red blood cells, no white blood cells, no casts, nothing to suggest ATN, but there's heavy proteinuria, and so the dipstick will stain positive for protein. And if you measure specifically urine albumin to creatinine ratio, could be very high in the nephrotic range. And so this would suggest there's a nephropathy present. There's some sort of problem at the level of the glomerulus. And so obviously a urinalysis and a urine microscopy can help you determine which of these diseases are present in the kidney, and certainly can help you with your differential and patient care. Overall, I think a lot of nephrologists think like this. At least, the clinical assessment is key. Understanding the patient's fluid status and effective circulating volume is key. Thinking about the structure of the kidney, the flow in and out of the kidney, is that adequate? Make sure there's no clot or compression. Make sure there's no urinary obstruction. So imaging is required in a lot of patients. And then, urinalysis and urine microscopy, they're inexpensive, they're ubiquitous, and you learn a lot of information. And I think this sort of schematic here shows you how much information you can truly learn from a urinalysis and urine microscopy. And so I hope this helps. I think it organizes things. And remember, patients in real life aren't always as easy as a schematic like this, but I think it is a great place to start when you're approaching patients with acute kidney injury.